Thank you so much for joining us today. My name is Nushka Oberlak. I am Vice Chair of Compassion in Dying, and I'm chairing the webinar this morning. In the sphere outside of the internet world, I'm an anaesthetist and an Associate Medical Director at my NHS Trust. I'm very excited to be chairing this meeting because I truly believe that people should be aware of how they can record their wishes for their end of life. And I believe that should be an easy process, which everyone has access to. So I'm excited to hear about the research from the University of Leeds and how we can apply this to our healthcare as it currently stands and in the future. There has been increasing recognition of the urgent need for innovation in digital records. Last year, the Times Health Commission called for the creation of digital patient passports. Much discussion has also centred on the federated data platform, but for many, this has overshadowed the progression in overhauling digital records. What's clear moving forward is that the starting point of effective design must be the needs of the users, the people themselves. For those of us working in healthcare, we know there is widespread variation in the types of systems available to record end-of-life decisions electronically and much variation in how these are used. How they are defined, explained and used varies wildly depending on where you are in the UK. For people able to access the system where their information is recorded, shared and respected at the end of life, the impact on their end-of-life experience is vast. You'll hear from speakers today that people say having their wishes shared means not having to repeatedly talk to healthcare professionals across different settings about their loved ones' wishes at a time that is already stressful. Others say that having their wishes shared effectively means they trust that their wishes would be known about and respected in the future. The good experiences we hear across healthcare settings demonstrate the impact and importance of getting things right for both patients and their loved ones. But this is in stark comparison with what happens when wishes are not recorded and shared seamlessly. What's clear is that getting digital systems right for patients is not an add-on to good care, but rather it's central to it. So we're here today to ask, what do people themselves want and expect a digital health record to do? How should health and social care professionals be using them? What are the outcomes for people and the healthcare service when digital records work well? And how are different areas in the UK innovating digital end-of-life records? Today, we will hear from people working across this sector. We will hear from those researching digital approaches to support advanced care planning, from people exploring the systems to seamlessly share these plans, and from people who actually use those systems, the patients themselves. All perspectives are vitally important to contributing to better outcomes for dying people. Going to talk about a bit of housekeeping now for the webinar. First, we will hear from each of our panelists. Then we will open up the floor into a discussion with the opportunity to answer your questions. Because we have so many attendees this morning, which is fabulous, we will not be able to see or hear you, I'm afraid, but we would love everyone to get involved by asking their questions. So please ask your questions using the question and answer function. This might be at the bottom of your screen or somewhere else, depending on the device that you are using. You can ask a question at any time, and we will answer as many as possible later on in our discussion section. Please try to keep your questions as succinct to help us respond to as many as possible. I will also just remind you that today's webinar will be recorded and available to watch back later via the Compassion in Dying YouTube channel. And we've had a change in the lineup today. Hannah Wall, who was going to speak about the Connecting Care Records project, is unfortunately not able to join us. But in her stead, we have Dr. Ian McNichol, who will guide us through what developments are happening across the country in terms of information sharing and what's possible looking into the future. So, starting with our first speaker, Matthew Alsop. Matthew is an Associate Professor of Palliative Care at the University of Leeds. He's going to talk about the national 3-year study which he led, looking at how electronic end-of-life records are being used across England. The study identified key elements to consider relating to the technology infrastructure and people who are using electronic end-of-life records. Thank you, Matthew.
Thank you very much, Anushka, for the introduction, and also thank you very much to Compassion in Dying for the opportunity to share our findings as part of this webinar today. And I'm going to start by briefly mentioning how we got to where we are with current digital end-of-life records in the UK. So over the past 15 years, digital end-of-life records in the UK have undergone significant transformation. What began in 2008 in 2008 as simple registers to identify individuals nearing the end of their lives, ensuring that they receive priority care, has evolved into a more comprehensive system. So today, these digital records are not only used to recognise those approaching the end of life, but they now also capture and share a person's preferences for future care. Originally, these digital records focused on supporting clinical decision-making, and they included details such as where a person wished to be cared for and their preferred place of death. However, with the release of new standards at the beginning of 2023, the scope of these records expanded, and they now aim to capture not only care preferences, but also a broader range of personal information reflecting what matters and is important to each individual. From our perspective, in terms of research team, despite more than a decade of development, there's actually been surprisingly little research on how these digital records are being used in delivering care. So at the University of Leeds, we've recently completed a 3-year project to explore this sort of very question. And our research was conducted in partnership with King's College London and Hull York Medical School, and it was funded by the National Institute for Health and Care Research. And we gathered insights from over 700 participants, and this included patients, carers, health professionals, and commissioners of palliative and end-of-life care services across England. I'm going to start by briefly talking about our work with commissioners and health professionals, and then later my colleague, Jackie Birtwistle, will provide an overview of findings from discussions with patients and carers. So our whole project began with a survey of palliative and end-of-life care commissioners across England to assess the usage of digital end-of-life care records. And we discovered that while around 2/3 of commissioners worked in areas that had implemented digital end-of-life care record systems, a significant number, so it was actually 28 clinical commissioning groups that took part in the survey, had no digital end-of-life care record system. In the areas where digital end-of-life care record systems are in place, only 1/3 of people had a digital end-of-life record at the time of their death. And the majority of these were people living with cancer. And furthermore, among those who did have a record, again, only a small fraction, so only 1/3 of those people had records that contained key information such as their preferred place of death. So when we looked at all the data, put simply, where systems are being used, less than 1 in 10 people have their preferences for care documented in digital end-of-life care records. And this raises a really crucial question. Digital systems are evolving to gather more information that's important to patients and their carers, but why is there such limited engagement with these digital end-of-life records? So to uncover the reasons, we spoke to a wide range of professionals who are on the ground using them, and this included doctors, nurses, care home staff, paramedics, general practitioners, and hospice workers. So we were covering primary, secondary, and tertiary care settings. And we found sort of 3 key findings. So firstly, we found a lack of clarity about digital end-of-life records. There was widespread confusion among the professionals using them about who digital end-of-life records are meant for and who's responsible for creating and updating those records. So this lack of clarity may contribute to the low number of records being created. Secondly, most digital end-of-life care records are trying to be everything for everyone at the moment. So many of the digital end-of-life records currently in use are not tailored to meet the diverse needs of various health professionals. So for example, ambulance teams often require quick access to accurate information about people who may not be known to them, while palliative care teams, GPs, care homes, for example, may need systems that allow them to document, update, and share detailed advanced care planning information. And we also found barriers to information sharing. So a significant issue was the lack of interoperability, or the ability of these systems to share information across lots of different settings. And that often meant that particularly care homes and ambulance trusts weren't accessing really crucial information. So there's lots of challenges, missed opportunities in terms of current use of digital end-of-life records. Looking to the future, we think there's a few ways that these the digital end-of-life record systems might be changed to improve them. So firstly, for the approach to be effective, there must be clear and agreed shared practices across different healthcare settings. It's crucial to agree on which professionals should be completing the digital end-of-life records and be clear about who they're intended for. Also, without systems that align with their specific needs, health and care professionals may be less inclined to use them. And lastly, we need systems that smoothly and effectively share information across care settings so that key information about individuals is available to all care teams when needed. Yeah.
Thank you, Matthew. And that was really good, sticking to time. I thought it was so interesting that there were a group who had access to digital records, but only a third were using them. The reasons that you found in your study, it's education, 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 isn't it? It's for a lot of it. So thank you for that. Moving on to our next speaker, Miranda is tongue-tied, is living with stage 4 breast cancer and will tell us about her experience of making end-of-life decisions and ensuring they're known about across different healthcare settings. Thank you for joining us, Miranda.
No problem. Thanks for hosting me. It's a bit weird talking about death of me being 42 years of age, but it's something that regardless of sexuality, cultural issues, faith issues, or whether I have children or not, it's something that as a nation we don't really discuss, especially with myself having West African parents. It's the talk of death can be seen as being taboo. So a lot of things aren't talked about or discovered until after the death. So you just have to go along with what you think is suitable, but it might not have been what the person, the deceased, wanted or needed. So I think this conversation in regards to making sure that plans are put in place, that people who are near their end of life are able to demonstrate that this is what their intentions are. In relation to myself, because I was diagnosed, funnily enough, tomorrow will be 10 years since I got my first primary diagnosis. And it just put into place in terms of getting stuff done, especially when with my secondary breast cancer diagnosis, making sure that people knew exactly what was going on, because some people thought secondary meant that it had come back, which, you know, it can do, but it's not called secondary, it's called like reoccurrence. So just making sure that people were aware that, you know, I wasn't going to sort of get better unless there's a cure. But in the meanwhile, it kind of gave me the impetus to get things sorted out in terms of drawing up a will, making sure that certain people, like an executor or family members or close friends, were able to know what I wanted and be able to implement them. And as well as the oncology team know what intentions I wanted. For example, they said that if the worst came to the worst and you needed to use CPR, do you want to use it? And I said, well, you've explained what it is, and that if you want to, if you do have it, then there's no guarantee that you would be the same person as you were when they were revived. So it's just, when you hear that, I just think, well, kind of, if I hadn't done anything with my life, then I would kind of question it. But because I would say I've had like a really good life, like I'm doing the Great North Run in a few weeks. I've jumped out of an aeroplane. I've well, tandem skydive, and I've done lots of other stuff like being an extra on Shaun of the Dead, that sort of thing. So it's kind of like, if I have to go, then I have to go. But I think it's important to make sure that, the patient is thought of first and what they want, and then being asked the question, and being able to sort paperwork, or tell people that paperwork has been sorted, so they can be able to make decisions without having to make the decisions by themselves.
Thank you, Miranda. What I heard there is just how important it is to be able to record your wishes, and how having a way to access a method to do that can actually help overcome cultural barriers. Would you say that's fair? Yeah, great. Thank you so much. That's really helpful. So moving on to our next speaker, Usha Grieve, who is our Director of Partnerships and Services at Compassion in Dying, and will share findings from our research and from the people they support on what matters most to people themselves when sharing end-of-life wishes. Thank you, Usha.
Thanks, Anushka, and hi everyone. It's great to be here to talk to you all today. And firstly, thanks so much, Miranda, for sharing your personal experiences so generously. As Anushka said, I'm going to follow you by talking about what the people we support at Compassion in Dying say about their electronic records. And specifically, I'm going to talk about three things. So one, people really care about this. Two, people have clear ideas about what they want their electronic record to do. And three, digital systems are meaningless unless health and care professionals use them. So firstly, people care. On our nurse-led information line, about 1 in every 20 of the calls we receive are from people who are worried about how to ensure healthcare professionals will know their wishes when it matters most. And they go to, like, some of the people that we talk to go to great lengths to make sure that their decisions are known and can be respected. So they contact their local ambulance service, their local hospital, they carry cards in their wallet sometimes, they wear jewelry, they give copies to their neighbours, families, friends, and they put stickers on their front door alerting people to where their health information is kept in their home. And this is felt particularly acutely by people who are isolated or don't have family to advocate for them. And what we hear very strongly is that people want their end-of-life wishes to be heard and known. Secondly, people know what they want from their record. We conducted some research for NHS England in partnership with the PRSB on electronic records, and I'm sure it won't come as a surprise to anyone here when I say that in many areas, people said that the current system for sharing end-of-life information did not align with what they actually needed from it. Around 1,700 people took part in the research, and people spoke with incredible clarity about what they needed. And I think this is really important because we all know that this is a really complex landscape, but for me, bringing it back to what people themselves need is key to getting it right. So they said electronic records need to communicate people's health information and end-of-life wishes seamlessly across care settings. And people use the word seamless a lot. Specifically, they mentioned sharing information between GP surgeries, paramedics, hospitals, and care homes. Electronic records need to travel between geographical boundaries, and this has already been mentioned. People cited experiences of receiving care and treatment in one hospital, in more than one hospital, in different ICBs, or moving house or visiting family and needing to know that their health information and wishes would be instantly available in a new area. At a minimum, people want to be able to view their record. They want to see what information is available to health professionals, and some want to be able to edit and update the information either themselves or alongside a healthcare professional. And people said this would build trust for them in the healthcare system. It would give them trust in their care and allow them to live well with their condition. And I think this is a really important one. Information in paper documents, like an advanced decision or in DNA CPR forms, must be easily visible in an electronic record. And I'm hoping that Ian is going to touch on those kind of complexities and challenges around relying on paper when conveying people's decisions in his talk, which is coming up shortly. So on to my last point. Health and care professionals need support and training to use electronic records. This whole conversation is often about how data is shared, interoperability, IT systems. But even if we have the perfect system, it also relies on healthcare professionals who are supported, trained and confident to look in a record and know what to do when faced with the wishes and the information contained within it. In our research, large numbers of people told us about an experience of a loved one's recorded wishes not being known about when it really mattered. So we heard accounts of DNA CPR decisions not being communicated to a clinician when that person moved care settings, and CPR therefore being given against the previously expressed and recorded wishes of that person. And this shows why it's so important to have electronic records that work and are looked at. So alongside much needed changes to electronic records and how they're delivered and implemented, there also needs to be an increased focus on implementing, policy which sets out so clearly how palliative and end-of-life care must be personalised and based on what matters to each individual. Good innovation can't make a difference if it operates in a vacuum. So if we want a digital solution that enables people's priorities and their wishes to be known and followed, and therefore a system that respects their decisions and upholds their autonomy, then we need to look at also at building public trust and ensuring their healthcare workforce can use the records effectively. Thank you.
Thanks, Usha. So our next person speaking is Dr. Ian McNicol. Getting tongue-tied today. Ian McNicol. He was a former GP and health information and has worked health informatician and has worked with numerous digital and palliative care teams on sharing key information and wishes. Thank you, Ian.
Thanks, Anushka, and thanks for the invite to talk to you today. It's a shame that Hannah couldn't make it. I was actually quite interested to hear what she was going to say. I'll try to fill that gap as best I can. So yeah, I'm just going to pick up on something Usha said, which is about, this is about making information available in the gaps. It needs to be available rapidly, accurately. Sometimes people, particularly first responders, need to have this information quickly. They're in a chaotic situation. It has to be independent of location and circumstances. And I had my own experience of this. My dad had advanced dementia, was transferred from one unit to another, and was inappropriately resuscitated. Thankfully, no great harm done. He died peacefully some days later, but it was a lesson. And no blame on the clinicians involved. They made the right decision in the absence of any information. But had they known what his wishes were, that would not have happened. My own background was as a former GP, but I've been involved in this sort of specialised clinical implementation role for around 15, 20 years. And not all of my work has been on end of life and care planning, but increasingly we've been involved in that. Some English EPACS projects, in Scotland called KISS, Key Information Summary, which is broadly similar. We were involved in digitising the Respect Form, which has gone live in Scotland. But more recently, also the One London Universal Care Plan, which some of you may have heard about. I think that's what I really want to focus on, because I think it possibly is there are some lessons there, and I think a pointer to the way things should potentially work in the future. So the One London Universal Care Plan was really a migration from the original Coordinate My Care system. But actually, a lot of the design thinking came from some work that Karen, who's going to talk to you later, was involved with. We were both involved with a project called Rosie. Rosie sadly didn't go live, but many of the ideas that I'm about to tell you about came from that Rosie project. In fact, we used a lot of the work there. And the idea with the One London Universal Care Plan was that it should definitely go beyond just end-of-life care planning, palliative care planning. It was seen as the start of a more person-centered record around care wishes, because as been, I think both Matthew and Usha have said, there is a continuum. And one of the phrases that some of our patient groups in the Rosie Project talked about, they said, well, these were people who had loved ones with learning disability, and they said, you're talking about this around end of life. They said, this is for us. This isn't really about end of life. You know, things like what are your wishes, your about me wishes, your advanced directives, communication needs. This is about information for life. This is the kind of information we are asked about every time we hit the professional services, and we have to answer this time and time again. You know, the DNA CPR is the least of our wishes right at the moment. And that sort of framed the way we've been thinking about those later projects. Is there's a continuum of information for life, and clearly at some point you pass into that. Now we have to have these end-of-life discussions. So the way that these projects have been set up is very much around a patient-centered source of truth. Right? This information should live at some level in a patient-focused record, not in a GP record, not in a hospital record, not in a social care services record. A custom-built data store where that data is available. Obviously, it's available to the GP systems, it's available to hospital systems and SaaS out of ours. But it's not held in those systems, it's held in a patient-oriented system. And the other part of that is an idea that we've been exploring, the idea of what we call a co-produced record. So it's not a patient record or a professional record, it's a co-produced record, and I've got a minute to go. It's been very successful. We've got 50,000 records and growing. Successes in context launch, you know, make this easy for clinicians to engage with. At times it felt we were battling against NHS England in terms of this idea of a patient-centric data store. But the latest iteration of shared care records, which I'm sure Hannah would have talked about, we're starting to see this idea of a patient-centric record at the heart of many other shared care records like York and Humber, the Greater Manchester, and the Great North Care record. So I think this time has come. Anushka mentioned the idea of a digital patient wallet. I think this is where we get the best start. And as part of that, we get much better communications of end-of-life information.
Thank you, Ian. Some really interesting concepts and ideas there. Our next speaker is Jackie Birtwistle. Jackie is a research fellow in palliative care at the University of Leeds and will share findings from the patient and caregiver strand of the University of Leeds research project. She will discuss what people themselves want from their end-of-life care records. Thank you, Jackie.
Thank you. So as part of our project, we spoke to patients and caregivers to hear their thoughts on using digital systems to document and share important information with health professionals involved in their care. We wanted to understand their experiences, concerns, and how they felt about these systems potentially shaping their future care. To get a broad perspective, we spoke to 44 people in small groups or one-to-one interviews. And we focused on individuals who were living with terminal or life-limiting chronic conditions, as well as current and bereaved caregivers, to ensure we were capturing a wide range of experiences and insights. Throughout these discussions, 3 key themes emerged. The first theme was trust or lack of it in digital end-of-life care plans. Many people were uncertain about what exactly was being recorded in these systems and whether the information would be reliably shared with their healthcare professionals now and in the future. People often assume that these digital systems work just like the ones used to share their regular medical information, and the experiences of that varied. Most had found that all their medical information hadn't been available to health professionals in the settings they expected it to be. Interestingly, only a small number of the terminally ill patients we spoke to had used a digital system for advanced care planning. Some had different components of a care plan, like an advanced directive or a respect form, and these were often stored in various places or even multiple places, and sometimes multiple versions, whether on a personal computer with their GP or on paper. Some of these plans were created independently. There was a lot of confusion about whether this information could be easily shared across health settings. And for the people that have made their own, some didn't even know how to begin sharing it with health services. The second theme that stood out was the need for meaningful involvement in decision making. People understood that having quality decisions about care preferences was crucial, especially since their decisions could eventually be viewed and used by healthcare professionals who don't know them personally. Yet they were worried that the health professionals they commonly see would not have the time to engage in these deep, thoughtful conversations that are necessary for making choices about future treatments. And if this information is going to be shared widely, it's essential that it's accurate and reflects their true wishes. The third theme was about the value of having a shared digital advance plan. Patients emphasised how important it is to document their personal preferences, things like their values, their likes, dislikes, and the kind of environment they preferred to be in came up just as often as resuscitation preferences. They wanted their record to contain enough of their medical information for health professionals to know about the condition, medication, and which services they attend. But this was the type of information they did not want to repeat time after time when they saw new health professionals. At the same time, they were keen to discuss advanced care planning information more often, as it was reassuring to know that information such as preferences for treatments, including do not resuscitation, were being checked with them. Well, many liked the idea of accessing their own plan if they were concerned about the accuracy of shared information. They preferred to contact a health professional to update or correct rather than edit it themselves. And they really wanted to see which health professionals were accessing and engaging with their information instead of it just sitting there. In summary, while there's potential in digital systems for advanced care planning, building trust, ensuring meaningful conversations, and giving patients control over their information are key to making these systems work effectively for those who need them most. Thank you.
Thank you, Jackie. Lots of interesting outcomes from the research that you did. I especially like the point that they wanted to have a healthcare professional with them whilst editing the info, but also wanted to have access to see who was looking at their info. I think that's actually really interesting.
Yeah.
Thank you. Moving on to our last speaker of this morning, it's Dr. Karen Chambley. She is the Chief Clinical Officer at St Helena Hospice. She will share what they are doing in Suffolk and North East Essex to ensure as many people as possible have their wishes recorded digitally, and what makes the difference to people's end-of-life experience and what's possible in the future. Thank you.
Thank you very much, Anushka. Yes, thank you. My name is Karen Chumley. I'm a GP and a hospice director, and I have a role in leadership and end of life for our system. And I've been a clinical lead for our version of a digital record called My Care Choices in North East Essex for about 10 years. And I think it's really interesting. I really welcome this research because it resonates with our experience. And one of the things we seek to do is continually learn and improve the system that we have. So we've used the My Care Choices for 10 years, and we have roughly over time, about 50% of our population who die each year have had some opportunity to record their preferences. And we have had a good uptake in people recording their place of preference. So although the national average is 30%, there are areas where we've managed to embed it further. I think one of the reasons for that success is that we did address that issue that Matthew was talking about clarity of responsibilities. And there was a commissioning decision early on to address the costs in primary care of the proactive consultations and the administration around asking people what's important to them and then uploading it on the system. So there was a clear process And I think addressing that has really helped that in our area. We do also know that when people are on life care choices, they have a very high chance of being cared for in their preferred place at the end of life, and a much lower chance of dying in hospital and of recurrent admissions at the end of life. And they're things that in consultation with our population, people said were important to them. So we can see this association between people who've recorded their choices and people who've received better outcomes as far as place of care and avoiding unnecessary medicalisation if that's what they don't want. So to some extent, we have had some successes, but I think we haven't arrived. We're still continuing to learn, continuing to reach out, and we've tried multiple ways of doing that over time. We've done promotional campaigns straight to the population, raising the profile of the My Care choices, so that isn't something that the doctor always has to think of or the palliative nurse has to think of, but that people are aware of it for themselves and their family and can proactively seek to be involved in their care. I think some of the other reason that it's successful is that our system has been embedded within a 24-hour single point of access for people in the last years of life, which has helped us overcome some of the barriers which we haven't done technologically. So, for example, we still have barriers locally to information sharing. Some of the things that Matthew talked about around barriers for example, our paramedics. They cannot see My Care choices when they're in their ambulance. They can only access that information if they ring their clinical hub or if they ring our single point of access. So we really welcome our next wave of development, which is around linking our register to something called a national records locator, which is a way of flagging that to the paramedics on the ground. That's also been an issue with our out-of-hours service, who can see it, but it's slightly clunky. So there are barriers in that information sharing. But we have worked over time to reduce those barriers for hospital colleagues, for example, who can now see that information seamlessly. And that's been really helpful in getting people an early review if they do go to hospital by the right team who are informed about their decisions. I think also what I'd like to say is that an EPACS gives us a real opportunity to highlight people's outcomes and follow through what happens to them. So when people go on our local register, we ask if they'd like to be part of a survey, and then we ask them once a month by text message whether they've received care that's right for their needs, whether they've been treated with dignity, whether their pain and their symptoms are controlled. So we've used our EPACS to really communicate with that population, which has helped raise the profile of what's important to them. So in summary, we haven't arrived. We believe that an EPACS tool is a really good system. We continually need to reinvent it as technology develops, but we have seen a clear association in our area with people that have been able to access it and an improvement in in achieving what's important to them.
Thank you, Karen. Okay, so now we move into the question and answer part of the webinar. Can I ask and remind you to all use the question and answer function to pose your questions and tell us a bit about who you are and why you are interested in digital end-of-life records. Okay, so question one is to all the panelists. If you could change one thing to improve the way electronic records work, what would it be? So first question, I'm going to Jacqueline.
If I could change one thing.
One thing.
I think at the moment, as things are standing with systems, there would be something about location of records, because when we came into this, we were thinking that a record was here, but it wasn't there. But we were actually finding that records were in multiple places, in multiple versions, and patients didn't really know the limits of how far their data was going. So with the systems we've got at the moment, I would say it was something about knowing where the limits are. I mean, clearly it would be great to have systems like those that we use in some of the care homes we spoke to, that recorded everything about that person. And if those systems shared out, then that sounds like that would be sometimes a better idea than NHS sharing in.
Thank you, Jackie. Ian.
I'm probably just about to directly contradict what Jacqueline just said. I realise.
Sorry.
If I get what you said, and the thing I would say is stop trying to share out from existing systems. You know, stop trying to share out from a GP system or a care home system for a lot of this quite complex data that we need to get right. Because trying to synchronize them when one person changes in one of these places, trying to synchronize that technically across all of the different places you might want to read that data actually becomes incredibly difficult. So my thing was going to be stop seeing the GP record or the care home record or whatever as the source of truth and start to think in terms of a patient record that we all contribute to.
Okay.
Controversial.
Matthew?
It's a tricky one. I was thinking something around kind of harmonizing all the activity that's going on. I think it's a confusing landscape for health professionals, health and care professionals, and patients. You've got EPACs, respect forms. You know, you've got other kind of public-facing forms that you can complete to document your wishes. Having some way of bringing all that together. There's this kind of digital advanced care plan that is comprehensive and in some way tries to bring all that together in one place would maybe simplify what is an increasingly complex, messy landscape, I think.
Karen?
One thing, I'd make them visible to the person. If I only was allowed one thing, that's the key thing that I think would be transformative locally.
Miranda?
I would say pretty much what's already been said, that there needs to be some sort of collaborative form of gathering information to make sure, for example, if you have to sort of move certain countries, like from England to Scotland or from Scotland to Northern Ireland, that you'll be able to access this information, if not remotely, then at least like if you're able to speak to a GP or something where you previously were and they've got the information and they can pass it on for when you are in that situation where you have to deal with end of life situations.
Thank you, Miranda. Usha?
I would say that with all these things, I think trust is really important. And so I would echo what Karen said in terms of people being able to access it. And I think that if everywhere had a system where people could go and were encouraged to consider certain specific end-of-life decisions if they wanted to, there's an opportunity there to contribute to a kind of societal culture change where people come to expect these questions more. Because I think really what you want is people to reach end of life or a crisis having already thought through their decisions if they have an opinion about what's important to them at the end of life.
Thanks, Usha. So our next question, to Karen and all, I live alone by choice, and my concern is if I should die suddenly and ambulance teams or hospital staff are aware of my records and have access to them, how can I ensure my records are shared widely to GPs and so on, so there is no confusion? So Karen, would you like to kick us off on that?
Yeah, so it depends what your local system is. And I would start by having a conversation with your GP saying, these are my concerns, this is what I would want to happen. I think there's something there around talking about scenarios. So what if you were collapsed, how would somebody notify the services, and then what do you want to happen? And I would, with the information that you have around how the systems are shared. So in our area, we would want you to be on the My Care Choices register. We would want you to have a respect form, and we would, if you were unable to say, if you were too unwell to say I'm on My Care Choices, to flag that, then sometimes we do very old-fashioned interventions, like have a sign up or something in the home that says I'm on My Care Choices, to flag it to a paramedic if the person themselves is unable to speak in that. So we've used a mixture of new and old technology for the person that lives alone, if you're unable to articulate that when help arrives. So in the first instance, I still think that that's the role of the GP, or perhaps a palliative care nurse.
Okay, Usha.
Yeah, I think it, as Karen said, it just comes down to, you know, where you live, and where the systems that are available to share wishes are so different depending on which part of the country that you live in. And actually, if I may pivot back to the original question, the first question about, you know, what one thing would help, I think the other thing that would help address this is like a national mandated recommendation of what, at a minimum, end of life, like palliative care records, should be able to do in terms of information sharing and how that information is shared, because I think that would go quite a long way to addressing the postcode lottery. But ICBs need a clear pathway of how to commission it and implement that as well. It's not just good enough to say, you know, do it. And that's why it's great that there are examples like UCP in London who are kind of paving the way for what that could look like with that access across care settings.
Matthew?
Just to echo, Usha and Karen, really, I think it's entirely dependent on where you're based. In Leeds, for example, just to sort of talk about the local system there, the conversation would typically, in terms of an advanced care planning conversation, would be expected to happen between a patient and a GP or some hospice staff, specialist palliative care teams. They're the people that can create the records and update them and add information, and that should then be shared out. But that's as far as it goes. So that would answer the GP aspect, but it can be viewed by hospital teams, but then it can't be viewed by care homes. It can't be viewed by the ambulance trust. So yeah, it's entirely dependent on where you are. In Leeds, GPs would know, specialist palliative care teams would know, but a lot of other settings wouldn't. So yeah, it's entirely, I think Karen and Usha have given great advice in terms of, in that, but that's just the situation at the moment. It's really sort of patchy across England in terms of what systems are doing.
Great, thank you. And that helpfully answered a question from Gwen in the audience as well. So I hope that was helpful, Gwen. Our next question from Matthew Hutton, Northamptonshire's ICS digital lead. Do the panelists think that digital recording of respect forms should be mandated in care systems as a first step? So I'll go to Ian first for this one.
Ooh, controversial. I'll be blunt. I'm going to say no. So first of all, I am a huge fan of the respect process, and actually it's a very beautiful and quite functional form. But one of the experiences that we had is that it's actually quite difficult to integrate a very specific form with a very tight purpose with the broader idea of care planning. There's a lot of crossover, and it's quite difficult to manage. So one of the conversations we've had with the Resuscitation Council is what we've called deconstructed respect, which is the respect methodology and actually a lot of the data points, but not necessarily the form as a physical entity or even a digital copy of that. That's controversial, but I think we've seen this ping out. I know Karen may say something on this. We did find that challenging in the ROSI environment. And I know it's one of the reasons that London has decided not to use respect. Although, in fact, if you look at the data in their system, it's actually very respect-like. So I'll leave it at that. Others come in.
Thank you. Jackie. Oh, you're on mute, Jackie.
Sorry, can you just repeat the question again?
Right, so the question is from the Northamptonshire ICS digital lead. Do panelists think that digital recording of respect forms should be mandated in care systems as a first step?
I don't really know about that. Some of the people that we talked to, the health professionals, said that they would only do paper versions to ensure that that was the version. Yet we'd spoken to patients who seemed to think they had more than one copy. So I think it would be great to have it mandated, but I'm just so wary of out of date and cross-firing of versions just from our research. Yes.
Yeah.
So that would be my concern. But if it could be done, then great. But if it's different to what the patient holds in their bag and the family's seen, then that could cause an issue too.
Yeah. Usha.
We'll just sort of build on both Ian and Jackie's points, to say that in an ideal world, I think what we all want to move towards is a system where people's wishes don't have to be carried around with them in their bag on a piece of paper. You know, it's fraught with complexity, sharing paper forms. So, you know, in my mind, what we'd like to see is a world where DNA CPR decisions, respect forms, advanced decision to refuse treatment forms can be done and viewed online, but that can't happen until you have a system across the country that you can know and trust will be able to share that information across care settings, across geographical boundaries in an instant way, in an easy that's really in a way that's really easy for the clinicians that are using it. So I think in answer to the question, like, yes, in an ideal world, but you can't take the power of the paper form away until you've got a system that can share the records, the information adequately.
Okay, I'm going to move on to the next. Oh, sorry, Matthew.
I was just going to say, I think digitising isn't going to solve the problems, and I think we in Leeds we looked at respect data that's been digitised recently, and we've still got all the same issues with low completion rates in terms of what information goes in there, whether the paper or digitally stored. And actually, the risk is that we've already got EPACs, for example, in Leeds, which is the sort of the digital care record. Now there's respect that's also being rolled out in the community in a digital form. So actually, are we diluting or confusing what these records are supposed to be for? And actually, it could lead to even less engagement. We already know there's confusion across professionals about who should be completing what and who they're for. So I think that's just a reservation that I have.
Karen, you also had a point.
Yes, I'm just wary of the culture of mandating. I think that there should be a high level of expectation, and we're just about to launch a project called Expect Respect for people that go into care homes, a raising of the profile amongst that population and those that love them, and amongst care home staff. But mandating within structures like the NHS worries me that you can spin your culture from raising quality and raising expectation of qualifications to something that you can downgrade to something mandated and low level. And if you choose one population and mandate something for them without doing the others, that worries me a little bit around. You wouldn't say everybody should have a DNA CPR conversation, for example, in one specific population. What you want to do is be making sure that you're listening to what's important to that population, raising the profile of tools open to them and empowering them rather than mandating down. So there's something there around the power of the NHS to mandate that concerns me slightly.
Okay. Thank you, everyone. So possibly our last question. So question 4 from Anna Marie, Deputy CEO, End of Life Partnership, has been leading EPACs in Cheshire for 12 years alongside Dr. Sinead Clark. What is being done nationally to encourage or mandate IT companies to work together to deliver patient records that are accessible for end-of-life care? From our experience, this is often a key barrier as all of the different companies are trying to be superior. So I'm going to go to Ian for this one.
Yeah, this is the problem, and in a sense, this is why we so the current NHS England mindset until recently has been just let all these companies compete against each other. Different GP systems will get it all magically to interoperate. We'll have messages flying backwards and forwards, and I guess the UCP and others are saying, let's stop doing that. Let's just put this data on one place, and then yes, of course, all of these other companies can access it, but they're not the source of truth. The source of truth is to start to homogenize this and standardize it around the patient. Doesn't stop commerciality, doesn't stop people building things. So I think that has to be the answer, simply because it's actually incredibly hard. Even when the companies are prepared to do it, it's actually very challenging for them to do it accurately across all these very diverse systems.
Okay, thank you. Does anyone else on the panel want to add to that?
Yeah.
Okay, so the last question I have is for Karen and everyone. If we get to a point of the perfect digital end-of-life record, it's only as good as the healthcare professional who uses and promotes it. So how do we make sure healthcare professionals know about these systems, use them, and proactively encourage patients to start making advanced care plans? So Karen, if you could take the floor first.
By continual reinvention and imagination and engagement and networking. So I think you have to teach, you have to commission, you have to engage, you have to share stories, you have to share information, you have to find your local leaders, you have to offer peer support, you have to engage your students, you have to engage now volunteers, GP coordinators, and some of those others in primary care that are doing some of those discussions other than GPs. You continually need to look at how successful you're being and continue to reinvent. That would be my answer to that. And if anybody's got any better answers, please share them with me, because we're continuing to learn.
Does anyone else have anything to add to Karen's points, which I feel was quite all-encompassing, but go on. Yes, Matthew.
No, I think along the same lines, I think it's good evaluation and good marketing as well. I think what we found when we spoke to health professionals was that, you know, in Leeds, for example, GPs spend a lot of time filling out the information in these records, and then they disappear, or the health professional, the GP has no idea who's accessing it or using it or what the benefit of that record brings. So finding ways to feed back and share that information to demonstrate the benefit of these systems would hopefully sort of, you know, encourage greater motivation and engagement with them.
Anyone else got anything to add to that last question? Okay, so I think we've come to the time where we close this meeting, but I hope that these conversations have provided much food for thought on how we move forward with digital innovation. My own take-home messages are that visibility is a big aspect of how we can help improve engagement with recording people's end-of-life wishes, including digital end-of-life care record systems that we have available. I thought it was so interesting that in areas where there were systems available, there was still low engagement with it. People do genuinely care about their electronic end-of-life care records. Many experience significant anxiety that these records will not work in the way they are intended to when it matters most. So education to our healthcare professionals, our social care professionals, our emergency response teams, and to the public as well. I think knowing that these systems are available will also improve the engagement. When these records do work, both the person and their loved ones can experience peace of mind and trust in the system, and healthcare professionals to know about and respect their wishes. So we need to listen to our service users. We need to give them the time, as that was a concern, that they would not be given time to be involved in decision-making about their end-of-life care. So I hope you all enjoyed this morning's webinar. Thank you so much to Compassion in Dying's team for organising and putting this together, especially the support that we've had on the call today. And I hope you all have a lovely rest of your Tuesday. Thank you to our panellists on behalf of Compassion in Dying for joining us this morning. Your insights and contributions were so interesting, and they have given, I think, everyone food for thought, if I can judge that from the chat that is coming through at the moment. All very positive. So thank you very much, and we will see you at our next webinar.